right. So I'm going to go ahead and get started now while a couple more people trickle in. My name is Zaim Billah. I'm a current PGY5 Integrated Vascular and Interventional resident here at Kaiser Permanente Los Angeles Medical Center, working with one of my mentors, Dr. Vatican Cherry. Today, we'll be having a talk on the ethics and medical futility in vascular and interventional medicine. It'll be a multidisciplinary discussion. We have Dr. Makary here from The Ohio State University from their vascular and interventional department. And we have Dr. Arnold here from the palliative care space, here from University of Pittsburgh Medical Center. We're really excited to have this talk. It's a super important aspect of our field that I feel like is not educated on enough. I know myself personally, when I was on other services, a lot of time I would hear things like, I don't know what to do with this patient. Let's send them to the vascular and interventional service and see if they can figure something out. And that's something special about our field. We can come up with, creative solutions to some of these individuals who are really sick, but it comes with the responsibility to make sure that we're doing the right thing for the patient. And we're treating them according to their wishes in these, tough end of life scenarios. So I'm glad to have this discussion with both our field and palliative care. I'll give an introduction to our first speaker. That's Dr. Mina Makary. He's the director of the Inpatient Vascular and Interventional Radiology Service at the Ohio State University. He's published on bioethics and VIR with the incredible IR ethics team, and we'll be sharing his approach to these difficult scenarios in patient care. So I'll let you take it away. Oh, I believe you're muted.
Thank you so much for the kind introduction, and thank you and Dr. Vatican Cherry and everybody for the opportunity to be here today. I really appreciate it, and it's a huge honor sharing the stage with Dr. Arnold as well. I am happy to get started. Let me see if I can share my slides here.
Perfect. We can see your slides.
Perfect. All right. Well, we're going to get started. So my name is Mina Makary, and here's my contact information. If any of the audience would like to reach out at the end for questions or social media or numbers there. I have no relevant disclosures related to this topic. I want to acknowledge the Applied Ethics IR group, which I'm honored to be part of, and founded by my colleague, Dr. Eric Keller from Stanford, and others. Here is everybody's involved. For this talk, I'll be relying heavily on one of our papers from 2021. It was a case-based primer on some of these ethical issues that we explored, including futility. In terms of the outline here, what I'm going to try to do is I'm going to touch base on futility in IR. I'm going to review the approaches that have been published on how to handle this in a practical sense. And then I'm going to highlight those through a couple of cases. And the second half, obviously, will be Dr. Arnold sharing the palliative care perspective and then hopefully we have time for a Q&A. Talking about futility. So medical futility is basically care that does not further the patient's goals of care. And why is that important? Because it basically exposes patients to risks without the benefits. And as a result, futile interventions are considered unethical and should not be performed. In real life, however, many of the requests that we get in interventional radiology are not unequivocally futile. And this was recognized by multiple societies, and multi-society position statements have advocated for using the term potentially appropriate procedures to acknowledge the tentative and value-laden nature of these assessments. Potentially appropriate procedures may have the potential for achieving some of the benefit compared to totally futile procedures, but that's kind of more an appropriate term for what we actually face in real life. And often these situations arise in the context of end-of-life care, but they're not exclusive to this population, and this definitely needs to be differentiated from palliative care. Palliative care is care that also might not extend the patient's life or treat the disease, but it can provide relief to the patient and it can improve the quality of life. And Dr. Arnold will dedicate an entire discussion on that next. Understanding whether a request is potentially inappropriate or futile really relies on communication and relationship with the patient. So the patient-physician relationship and understanding the goals, understanding the patient's goals of care are key here, because that's the cornerstone of how to handle these situations. And those are the communicated goals and the shared decision-making process, sometimes with the patient, sometimes with a surrogate decision maker, will be what we will focus on. And at the end of the day, the responsibility falls on us to realize that providing potentially appropriate procedures does not necessarily provide the best care for the patient. And that's important, because a lot of times, we get faced with requests like, what's the harm, or, why wouldn't you do this? It may help, even if it most likely won't. And that's important because there are risks to these procedures, and not only to the patient, but also literature has shown that physicians that provide futile care often are linked to moral distress and burnout. So it's not just for the patients, but even for the healthcare provider. And also, we have to balance this understanding with the desires of the individual patient and the responsibility of the public who are contending with limited resources too. And this came into highlight, especially at the time of COVID, where we had to manage our resources in a way where we can take care of everybody in a safe and effective manner, and have to deal with futile care often. And how do you manage that? So there are many approaches. This is part of our previously published work. Basically, we advocate for talking to the requesting physician and team to clarify the goals of care, and considering a multidisciplinary discussion with the patient and the family. And it's important to reach out to the referring physician first, because interviews that were done with referring physicians suggest that they prefer that IR first ascertain from them whether they already clarified those with the patient. And if not, then IR should definitely suggest these conversations, and prior to proceeding if something is potentially inappropriate. And not only that, but offer to actually be part of the discussion, because we have a lot to provide in terms of clarifying the risks and the benefits and the mileage, and what the expectations are, which a lot of times it's hard to for the other teams who don't necessarily are not familiar with what we do to articulate these things. And discussing futility with the patient and the family, it's a tough discussion to have, but what you have to realize is that the perception of benefit is highly subjective, and it differs between the patients and the physicians. So what we might think is futile or inappropriate, the patient's family might say, we want everything to be done. And, what does that mean, and what that means? And I think one of the most, practical things that when you try to do these conversations is to consider how you phrase those discussions. And one of the things that we always say is phrase it in terms of the patient's wishes, or what he or she would have wanted, rather than asking the family members what they want or how they want to proceed. This allows for clarity in the decision making, and also avoids perceptions of guilt or not giving up, right? Because nobody wants to give up on their loved one. But if you say, what would you want to do this? Of course, everybody would like to do everything, even if it's, has one chance of success or not. But the best way to phrase it is, what would have this person wanted? And then that way you bridge the gap, and then help the family member, or the surrogate decision maker, know that they're trying to represent the patient's wishes. And even if those imply that no further care is needed, they should not feel guilty about that. So that's one of the key aspects of communication that we try to focus on, is the language. And sometimes, despite our best efforts, there's disagreement. So how do you handle that? I think considering third-party mediation and consulting the institutional policies on refusal to treat if available would be helpful. So what are some of those resources? So palliative care, ethics committee consultants are basically examples of potential mediators, and they have experience dealing with these situations, and they can be a neutral third party. Tumor boards also provide an important platform for multidisciplinary collaboration, especially in oncology cases of what treatments should be offered or not, from a perspective of multiple experts. And then institutions have increasingly developed policies for these situations. So check your own institution. You may have already a policy on dealing with this situation. And lastly, at a higher level, even multi-society position statements provide a stepwise approach for these situations in which clinicians and patients or families disagree. Here's a practical approach from Eric Keller et al. This was published in the CVIR in 2021. And basically, this starts even before. So at the time if you get a consult, let me see if I can make my arrow pointer here can be seen, laser pointer, here we go. So if you have a serious illness or potentially palliative intervention, then you look at it and you first review the patient's chart. Do they have advanced care planning during this illness or in the last 3 months? Did they ever express their wishes or their code status, or they have advanced directives on what they wanted or what they would not want to do? And if the answer is yes, then you proceed here and then you look at it. Is this potentially appropriate? And then if the answer is no, then you start engaging these discussions with the before you actually do the procedure by the primary team or the palliative care team and the patient and their family. And then you go to this potentially appropriate square. And if it's not inappropriate, you do the procedure. If it is potentially appropriate, then you do a consensus recommendation among the IR practice. And that is a very good point, because there's this phenomena of doctor shopping where there may be multiple interventional radiologists in a group, and some of them have different thresholds of different approaches, and some of them may be more conservative, some may be more aggressive. And you don't want to be in a situation where the referring team or other providers are doctor shopping and they get different answers on different days. So something like this, may be discussed among the partners or the colleagues, and this, is this appropriate or not appropriate? And once there's a consensus, you go back to the referring physician and discuss with them. And then if there's consensus with them and us, then we have multidisciplinary recommendation with the patient and their family. If there's no consensus, then we consult palliative care, ethics committees, and have a multidisciplinary goals of discussion, and go back to here to the recommendation to the patient and their surrogate. And then if the patient or their family accept the recommendation, then you go to the procedure if it is appropriate or not. If it's not, if they don't accept the recommendation, then you go into society guidelines or institutional guidelines. And in this publication, they refer to the critical care guidelines, which I'm going to show you next. Basically, the Society of Critical Care Medicine, SCCM Ethics Committee, established a framework especially for this situation and how to deal with potentially appropriate interventions. And it's a multi-pronged approach. This is the summary, and here's the reference for those who want further reading. First, you enlist expert consultation to continue negotiation. And then you give notice of the process to the surrogates or the patient's representative to say, hey, we started having everybody on board. Sometimes it's appropriate to get a second medical opinion if it's not clear. And then you review with the interdisciplinary hospital committee that looks into this situation to give the patient's surrogates the opportunity to even go to a different institution if they want to. This is in a case when there's a disagreement. And then inform the surrogates of the opportunity to pursue an appeal if needed. And then at the end, you implement the decision of the process. So that's how you deal with these difficult, often end-of-life situations. So I have only 20 minutes, but I'm going to highlight some of the things we talked about, which is, futility in IR. We talked about some of the practical approaches. Let's look at cases. And these are some of these were published before in our group by our group, but they highlight, very realistically some of the things that I personally see in my practice, for example. So the first one is a 79-year-old male history of alcoholic cirrhosis, so they have end-stage liver disease. They have a 20-centimeter recurrent ACC. They have satellite lesions. They have bone mets. They already had an ablation treatment, and this came back. Patient has significant pain, and they're referred for another treatment, for radioembolization treatment. And this is not referred for palliation. This is more referred to treat for treatment. Here's another one. This is an 80-year-old lady, had recent stroke, so her functional status is not good. The patient also has stage 4 metastatic small cell lung cancer, so that's a very aggressive lung tumor, and it's already metastasized outside the lung. She's been on the vent already for 3 weeks for COVID pneumonia. And if you remember from the COVID studies, basically, if you already are requiring ventilation, prolonged ventilation, then your prognosis is not very good to begin with, let alone with comorbidities and age. And then in this case, the team is asking for a G2 for long-term nutritional support. So as you can see from both of those cases, the first one, you've got age, you've got a massive tumor that have already been treated, has already metastasized. Patients already been having pain, and we need to focus more on what is important in terms of palliating their symptoms, improving quality of life, but nobody's necessarily focused on that specifically. And they're going for another second line treatment. In the second case, again, stroke, advanced cancer that is very aggressive, already with COVID pneumonia, with on the vent for several weeks, very poor prognosis, and they're looking for nutritional access. So those are the kind of situations we often face, and often these consults seem to have little, no chance of achieving meaningful benefit, but the teams are always thinking of what if, what if, what if. So how can you navigate these things? These can be very challenging. I think you have to recognize what the real challenges are, and sometimes, like these cases, these are obvious. Sometimes they're not. So number one, you have to recognize the limited abilities to definitively prognosticate. Right? We don't always have all the answers, and that's how medicine works. We work with the best of information that we have, but we don't always have all the data when we make our decisions, but we have to work with the best information we have. You also have to recognize, practice policies, right? Are we practicing clinical IR? We're actually through consultants and contributing decision-making, or are we just doing every procedure or every request that we get? Referral networks, right? Is the referring physician, this is your primary referring physician, and you're trying to build a relationship with them. And if you say no to this, would that create some distress in that relationship? And, should that be a factor or not a factor in your decision making? Diversity of patients and families' values. And this is kind of field where a lot of the friction often happens is, especially in other cultures, and that's something that's very important to think about is, in other cultures, the concept of palliative care or the concept of goals of care is not always defined. And the goal is always to do everything possible. And what you think, and I've alluded this at the beginning, as benefit versus risk might be different depending on that particular family's values and, again, culture. And often goals of care discussions have already been taking place by the referring teams with the family members, and they've already set expectations without IR, before the IR consult. So sometimes you feel kind of trapped because, maybe other teams that don't always know the full benefits and the full risks of what you can and cannot do. And they've already talked with the patient's surrogates and, set their hopes high. And you said IR will do this may help, may not help, etc. And then the conversation will be difficult. So this is published also previously, and Eric Keller et al., what they did is they looked at these factors and they grouped them into 4 groups that contribute to the IR's perceptions of futility and whether a procedure is potentially inappropriate procedure is performed. And they looked at it into 4 groups. So patient factors, so goals of care, clinical status, comorbidities, like I said, cultural beliefs, family preferences. Sometimes there are procedural factors. Is it feasible, technical feasibility, available data that we have, may not. We don't always have RCTs on everything. Invasiveness and risks, the demands in terms of staff time, skills, local expertise. Sometimes we look at clinician factors, past experiences, maybe that's their expectations. We do these things, time and energy, not wanting to play God, making the decisions for everything, or not knowing what, hard to prognosticate. Feeling compelled to do something. This comes up often a lot, where you have this conversation and you discuss the benefits and risks and all this, and then the team be like, "Oh, well, we know, I understand, but we have to do something." And having to do something, just to show that we're doing something, again, it comes at sometimes risk to the patients, and may contribute to futile care. Cultural factors, like I said, referring patterns, policies, not being the primary team. So, quote unquote, are we acting as true physicians and really contributing to the conversation, or are we just abdicating our responsibility? Reimbursement, fear of litigation, right? What if you say no, and then you get sued that you didn't do everything, and despite the patient's wishes or the family's wishes. So these are complex conversations. So at the end of the day, futility is complex and difficult to define. Each patient is unique. Sometimes the situations are clear, sometimes they're not. But at the end of the day, there's no substitute for an open, honest, and respectful conversation that emphasizes both the physician and the patient's perspectives. Communication, if it's one thing that I'll leave the audience with today, is communication. Communication between us and referring teams, communication between us and the patient, their surrogate, communication between everybody, ethics committees and palliative care, deliberation. All this is very, very important. And then beyond our personal approach, higher level solutions, for example, creating consistent institutional workflows that promote multidisciplinary goals of care and advanced care planning discussions. These conversations start early on rather than wait till the last minute before an intervention is needed. And integrating local resources such as second opinions and ethics committees and palliative care. And then raising awareness and education on these complex issues in multidisciplinary meetings, M&M conferences, tumor boards, training programs, discussions like this webinar. And then lastly, at even higher level, we need to have our own societal guidelines for approaching these things. And this can help us navigate these difficult conversations. So here's a shameless plug to our group. These are our top publications on this topic, and to my knowledge, the only ones that explore futility specifically in IR. And for the audience, if you want to have further literature on this, please consider reviewing these. And I am open to more questions, or probably after the second part with Dr. Arnold, we can have a group discussion. And again, here's my contact information for those of you who would like to reach out.
Great. Thanks so much, Dr. Makary. Really appreciate the discussion. I think we'll keep the discussion and questions for the end. I have some questions written down from both the chat and my own questions. But we'll go ahead and begin with Dr. Arnold's part of the talk. Just as an introduction for Dr. Arnold, Dr. Robert Arnold is Chief Medical Officer of the Palliative and Supportive Care Institute and Director of the Institute for Patient-Doctor Communication at the University of Pittsburgh Medical Center, past president of the American Academy of Hospice and Palliative Medicine and Society for Health and Human Values. He's published extensively on end-of-life care, doctor-patient communication, and ethics education, and is really here to share his expertise on this topic from a palliative care perspective. So thank you for taking the time, and without further ado, I'll let you have the stage.
No problem. Can we if Dr. Makary, if you could get rid of your slides, and if people are dressed, if they could turn their screen on, because I view this as much more of a discussion. I do want to say that, like the Society for Critical Care Medicine, I'm inclined to call these potentially inappropriate rather than futile interventions, because I'm going to focus on the second of Dr. Makary's two cases, the 80-year-old with metastatic small cell who's been intubated for 2 weeks, and you're being asked to put in a feeding tube. I want to be really clear. From a physiologic point of view, putting in a feeding tube isn't futile. On the other hand, you're very worried that it doesn't achieve long-term benefit, which is probably true. And I'll point out, if you've been in the cardiothoracic ICU or the transplant ICU, we do a lot of things that don't achieve long-term benefit. We do them for short-term benefit. A lot of the palliative radiation and palliative IR things we do don't cure diseases. They, in fact, prolong lives a little bit, or more importantly, they decrease symptoms, as you all pointed out in the chat. So my question is, when you get asked to do something that you say, oh, Jesus says this seems inappropriate, the first question to ask yourself is, why is who's ever asking for it? I want to promise you that no one comes to you when they call you on Friday afternoon at 3 o'clock and ask for something that they think is inappropriate. Families don't ask for things that they think are inappropriate. They ask for things that they believe have some value. So let's assume, for the second case, that 80-year-old woman, that the family has said, we'd like a feeding tube. For whatever biologic reasons, the primary team thinks an NG tube is no longer appropriate. Why might a family, in this case or in the case that someone put in the chat, a demented patient, why might a family ask for something which you don't believe is very useful? Take a minute and put in the chat why a family would ask for something that you think doesn't make sense. You can go ahead and send it. Feeding is a basic human right. Starving seems cruel. You think a feeding tube will benefit, so their belief is that it will benefit. Feel like they're doing something. To feel guilty because they had a friend with head and neck cancer who got a feeding tube and got better. They have prior experiences. So they looked it up on the internet, and on Google, that's what it says to do. So I just want to point out that when you get asked to do something that you think is inappropriate, the first thing to do is to take a deep breath. Because rather than telling them why you think they're wrong, you need to understand that every conflict, every really difficult conversation is really three conversations. The factual conversation, the emotional conversation, and the identity conversation. And this comes from a book that I put by Stone et al. Called Difficult Conversations. And it isn't about medicine at all. So let's look at the facts. We know that even, particularly in the hospital, that families have had a gazillion people talk to them, and yet they largely don't know and don't understand what they've been told, because we use jargon, because different clinicians say the same things differently, because the families are overwhelmed. So because it doesn't fit with what they've been told by people they trust for spiritual or ethnic reasons. So the first thing I want you to do is slow yourself down in these cases and find out what other people have told them. Find out what their beliefs are. Because what all the data suggests about learning is that we only remember things if they're tied to what we already know. So, for example, if this family doesn't want their loved one to starve, what they're telling you is, I have a belief that if you don't eat, you'll be uncomfortable. And I don't want my mom to be uncomfortable. Or they may have read about if you can do some fancy procedure, you can fix the bleeding, and they forget that fixing the bleeding won't fix the cancer and probably won't make a difference about whether they'll get out of the ICU. So first, rather than talk, make sure you understand the story. Second, remember that when you're giving information, what's the average health literacy of Americans? What grade? Just show me with your hand. What grade is average health literacy of Americans? It's 4th or 5th grade. The data suggests that 50% of Americans don't know what metastases are, which is why you see so many patients with breast cancer metastatic to their bone, and they say they have bone cancer. So I want you to think when you give information, to give information like you would be giving it to a 9 or a 10-year-old. And to think about what you really want them to know. If what you're really saying in the workroom is, we're worried that your mom is dying, then the headline that you need to give them is not a medically sophisticated headline that talks about data, but instead says, given where your mom is and all the things that are wrong, we're worried that she's dying. And for that, you need to, as Dr. Makary said, work with the primary team so you all are giving the same headline. Second, many of us make decisions not based on facts, but based on emotions. Imagine that it was your mom or dad or grandma or grandpa. You're feeling out of control, you're feeling hopeless, you're feeling guilt-ridden, and we need to attend to that. In our conversations, we need to acknowledge the emotions because they both reflect what's most important and because they help us feel centered, and we're more likely to trust doctors who acknowledge what we're going through. So some of the things when people say, well, we just hope she gets better, I'll often say, I hear you. You're a good son. You want your mom to get stronger. I'll often say, I wish I had more successful treatments. That is, I'll join with the family in showing them that I'm on their side. There's a whole literature about things to say when the family says they're hoping for a miracle. And I need to be aware of how to respond to those things because they're usually not factual comments. They're comments about emotions. When someone says, I don't want my dad to starve, it's really, I'm really scared. We heard a lot about focusing the conversation on what the patient would say. I love that. I want to give one small addendum. I don't ask people what their dad would want. Because what their dad wants is this all to be a bad dream and to get better. Want is what I'll call a fantasy term. If I turn to Austin and say, what do you want to be doing right now? I bet you it's not being on Zoom, hearing this boring old guy talk about medically inappropriate treatment. He wants to be in the sun with his significant other, having a somewhat alcoholic drink and listening to some good music. So want is a term that encourages people to give you fantasies. So instead of want, I'll often say, if your dad was sitting here and could hear all the things that we've been saying, what would his reaction be? What would he think? Because I want them to focus on not so much fantasy desires, but I want their sort of cognitive part of the brain to come to the conversation. So the first conversation is about facts. The second conversation is about emotions. The third conversation is about identity. We often get asked to see people who are demented, whose families want a peg tube. And I'll be honest with you, I don't care if we do a peg tube or not. Because to a certain extent, what I care about is that they are prepared that their loved one is likely to die in the next 3 to 6 months. We do a lot in medicine that is a very small benefit, e.g. not futile, small benefit, for people who are likely to die in the next year or two. I'm an inpatient palliative care doctor. That's my life. What I care about is that 6 months after the patient's death, the family can look back and say, we did the best we could in respecting our loved one's values. That's my identity. That's what my job is. Families have identity too, and for those of you who do any pediatrics, the pediatric palliative care literature is full of articles that look at how parents see their role, e.g. don't give up, e.g. look for anything that will help our child live longer, make sure the child's time is as comfortable as possible. How you see your role cues the satisfaction you have with your job and the choices that you make. So my job when I'm talking to families or patients is to see if I can see if their role can, and their view of their role can be more flexible. So rather than feeling like you have a role where your only job as a son is to help my dad live longer, I want to see if they can be more flexible in their role. Similarly, my job when I work with healthcare providers is to see if we can be more flexible in our roles. That is, what constitutes success for you as an interventional radiologist? Is it merely getting the tube in the right place? Is it curing diseases? Is it feeling like you've been able to maximize the patient's values? That is, how you view your role will, to a certain extent, change how you reach out to families and have these conversations. So I love GOG. Did I say your name right?
Yeah.
Yeah, I love your comment. To a certain extent, I'm a guidance counselor. I use the analogy of a travel guide. I'm a really highly trained travel guide. In the end, it's the family and the patient's journey. On the other hand, I'll often say, I'm really afraid it's going to rain on that picnic. Have you thought about, would it be okay if I make some suggestions? Finally, before we get to the questions, I want to encourage you. Often, patients and families make bad decisions because we offer stuff that we don't believe will help. There is no reason for you to offer treatments which are not standard of care, for which there is no data that you think it will make a difference. And when you offer them, because it's on your multidisciplinary list, and then the family chooses it, and then you're trying to talk them out of it, all you've done is set them up to make bad decisions. And I think that you all are probably set up all the time when the primary team says there's nothing more that we can do. I think you need X. Let's talk to the interventional radiologist because you're set up then. Because if they need X, is sort of like, how can you not give them what they need? So some of this is us doing a better job to educate our colleagues. And I also think it's okay to say, I'm sorry, that doesn't work. We don't do that. Otherwise, I think our decision should be based on, what would your dad say if he was sitting here? What's important to your dad? What is your dad worried about? That is, your job is to get their dad's values and then apply biological information to be able to make a recommendation about what scientifically you can do to achieve the values and what you don't believe you should do because you don't think it will achieve those values. So I want to make sure we have 15 minutes left for questions. So I'm going to end. I put in the chat an article we wrote about how to deal with conflict that Tony Bach and I wrote. And if you want other references, I'm glad to send them. We wrote a paper on how not to use the word want, a paper on how not to use the word need, and a different phrase that you can use. So I'm glad to take questions.
Thanks so much for that talk, Dr. Arnold. That was amazing. I really appreciate you just speaking from the heart and from your own experiences and your own expertise. I'll get the questions started with one of my own. You know, sometimes I have difficulty empathizing with situations that I've never been a part of. And, you know, I try to imagine what it would be like in their shoes, but it's different because I've never been there and I can't fully embrace kind of what the family is going through. How do you handle situations like that?
You could just say, I can't imagine what you're going through. Or you could guess. I mean, there are many things that as physicians we see that we've never been through. I haven't been through extreme poverty. I haven't been through, and yet I can imagine what those experiences are like. When the family says he was healthy 3 weeks ago and now look at him, I can imagine it's just happened so quickly that it's just hard to believe. The other thing I would say is that you don't have to be right if you're guessing an emotional story. If you guess wrong, the family will correct you. The family will say, oh no, it isn't that it's too fast, it's that X. So what they want is they want a genuine connection where you're trying to understand the experience that they're going through, because none of us know what another person has gone through. That would be my answer. Dr. Makary, what do you do?
No, I mean, I use the phrasing that you just mentioned because you know, it's hard, you know, it's and something again going back to language. I'm always trying to be careful how I phrase things. You know, I don't say, you know, it must be really hard. I always say, you know, it's hard for me to imagine being in your shoes. I think, like you said, you know, we deal with a lot of things that we've never been through. I think it takes just, you know, compassion and empathy and, you know, trying to put yourself in the context of not knowing the jargon, all these things, and imagining what would you be in their shoes. So I try to stay grounded in these conversations by simplifying things, by trying to have a relationship with the family, by trying to understand their values. And even though if I'm not, you know, that person's husband or son or cousin, you know, just understanding the context of the situation, I think as humans we can relate.
Great. Thank you so much for the advice. I'll definitely take that into my practice. What mistakes have you seen made in care or counseling that was provided prior to the involvement of the palliative care team? What are some common mistakes and how can we avoid these mistakes in our practice?
So this is for Dr. Arnold, correct? Because of the palliative care?
Yes.
Okay, go ahead.
So I would think the most important thing to do is to start off figuring out, don't talk about treatments, talk about values first. Figure out what they know, make sure if their understanding isn't the same as yours, that you give a clear statement about the biomedical situation. And then focus on values so that your medical recommendations are based on the patient's values rather than starting off with treatment options that aren't contextualized to the patient's values. The most important, the thing that I see the most is that we often aren't straightforward with families about what we really think is going on. It is too often that we think the patient is dying and the family has never heard anybody say, "We're worried that your dad is dying."
I agree. I want to just add a little bit to that. I think, you know, and I had even this conversation with one of my fellows recently because, you know, we a lot of times we end up dancing around the subject, and obviously we want to be sensitive to the family going through a tough situation. But if everybody's trying to sugarcoat the situation, you know, you're kind of indirectly giving them false hope, and it makes it a lot harder when things don't go well. So if I'm doing an immersion tips with a really high mortality and this and that, and you talk to the family and they're like, oh yeah, that 12 IR is just going to do the shunt and it's going to take care of the bleed. Well, that may be true. Would it be better to have, you know, have realistic context of how sick they are and why we're doing this first? Or would it be better for them to be surprised when something doesn't happen, they die, and it's just a lot of stress for the family? The other thing that I notice in terms of mistakes and when people consult palliative care, and again, this is just my conversation as an outsider, you know, Dr. Arnold is the expert here, is I don't think they get involved early enough. I think in a lot of places, palliative care gets consulted or involved, you know, kind of pretty late in the patient's course, where I feel if, you know, they provide tremendous value and can help guide the conversation, the expectations, and be a resource to us and the family and the patient and help improve their quality of life, etc. I think it'd be a lot better if they're involved earlier in the conversation than later, because they can really guide and help, you know, kind of coach and be that guidance counselor, as the comments were by Dr. Vatican Sherry. But I think when they get involved really late, or when us as consultants getting involved really late after the goals of care, these conversations happen and all this stuff, and we don't have a true multidisciplinary input early on, it makes it harder not only to relay the correct message to the family, but also to kind of correct, you know, quote unquote, correct the path if it's not going in the, you know, in a way where we all see it's appropriate. It makes it a challenge to say, you know, after somebody offered a G-tube, and if you think it's inappropriate, and then trying to walk it back, like Dr. Arnold mentioned, it's a lot harder than compared to having a helpful and realistic conversation from the beginning.
So I agree completely that palliative care, we love palliative care to be involved. I also would say that you all need training in this. This is as an important a thing that you do as any procedure that is core to your practice. And it's not something that most people get training in. And so the expectation that you can have these conversations just because you're a really smart person isn't the way it works. It's like doing a procedure. You need to practice, you need to get feedback, you need to get better, because there are never going to be enough palliative care clinicians to get involved for every seriously ill patient who has a high risk of dying. And so the hospitalists, the oncologists, the critical care medicine doctors, you all need to know how to have these conversations.
Absolutely.
Thank you so much for that insight. I have another thing.
Can I make one quick comment on that, asking patients or family their understanding?
Absolutely, go ahead.
Here's a hint. Don't ask their understanding, because that makes them feel like they're being quizzed. Say them, what have the doctors told you about X? So then the blame is, if they don't know, it's not that they're stupid. They don't know because they haven't been explained it correctly. It's our fault. The second point that goes along with that is I try to ask families at the end of our meetings, I try to do a teach back. Nurses can teach you how to do a teach back. A teach back is, we've talked for about a half an hour. Sometimes I use a lot of big words and stuff, and I want to make sure we're all on the same page. So tell me what you're going to tell your loved ones tonight about what we talked about. That's my way of just doing a double check on what they heard from the meeting. I don't have to use it. I'm not going to correct it because our time's up, but it helps me for the next meeting I sit down and have with them.
That's a great tool. I think that some of the way you word things is more helpful of a tool than what wire or catheter we use to get into a vessel, because it really frames the conversation in the right way. And that's what's more important to the family. They don't care what we do to get the procedure done. They care about, do we care about their loved ones, and are we guiding them the right way through these difficult scenarios? And this talk is really making me realize that. A great question came up a little higher in the chat. Expressing empathy sometimes can take a toll on us. How do we prevent carrying that toll home and affect our loved ones at home?
You want to go first or second?
It doesn't matter. I can go. That's a very good question. And it's not specific to IR, it's all of us at the end of the day, what you carry home with you and all the things that are on your burden, whether it's dealing with a tough conversation, whether trying to put your shoes in somebody's family's, situation, whether, if you had a complication, if you had a complication, and then how do you handle that, and would you bring that home with you or you don't? And all these things, take a toll on us. But I think again, having that empathy and that connection and the fact that you're trying to help, I think is what at least personally guides me through these situations, and how you feel like you're part of the team and you're treating them. What I don't like to see, and I've seen some people cope with these situations by compartmentalizing the whole thing, where they treat patients as procedures and they take the emotion out of it. And I think at the end you end up with moral burnout, and then patients become dehumanized. I think what you could do is just channeling that empathy, and then you're channeling that stress or that difficult conversation you have into actually helping the patients, and you're being part of the solution. And I think it's something that we all have to struggle with, but I think having that well-balanced approach, and then maybe Dr. Arnold can share some of his wise insights on this, how to deal with that.
So first, just as a scientist, there's no data that being more empathic leads to more burnout. And in fact, if you look at burnout rates in palliative care doctors, they're significantly lower than some other professions. The question is, my view of emotions is I feel the emotions, they pass through me, but they're not my emotions. I walk out of the family meeting 98% of the time, it's not mine. It's their sadness. The fact that I'm trying to be in touch with it to help the patient or the family doesn't mean it's mine. I can walk out and let it go. There are lots of tools to build resilience, from running to meditation to journaling. I would encourage all of you to think about what helps you feel grounded so that you can have conversations and let them go. I was reading about a culture, and I was just trying to Google it to see, we often say, I am sad. You are not sad. You have certain feelings. They are not you. I can feel sad in a room. It doesn't mean I'm sad. It's the Irish saying about emotions. Google it, you'll figure it out. but it's that emotions pass through you. They are not you. And to the degree I would argue you can reconceptualize, and it's particularly important for all of you to do early in your career so that it doesn't wear on you. They're not, the emotions aren't who you are, and you need to come up with ways to be resilient.
That's a very good point. You know, working with those emotions and channeling that compassion without letting it burn you out or hurt you. You know, so carrying it but not letting it affect you. That's a very good approach.
Oh, here it is. I found it. It's you don't say I'm sad. You say sadness is on me. So it's not viewed as an identity issue. I'll put the what I found in chat, and you can in the chat, and you can read it if you're when you're done. If you don't have anything to go outside, which would probably be way healthier.
Great. I'll just take one more question from the chat because I know we're at 1:01 and I know everyone wants to go outside on this Sunday. But the last question is, how do you serve as an effective guide when interacting with a variety of different cultural contexts and beliefs, especially those different from your own?
I think like Dr. Arnold mentioned earlier, you know, first is you have to listen before you say what, you know, what you're going to do or what you're not going to offer is to listen and understand the patients and the family's values. Even if it's in the same culture like you, each specific family may have different values. So it's not just a cultural issue, but often it is. But even that family is unique and they have their own values and goals and perceptions and understanding. And so I think listening and understanding, and I think it's a real skill to listen, you know, because you're not just hearing, but you're actually trying to process and actively listening to understand what they value and what is the underlying agenda, like Dr. Arnold mentioned, you know. Are they being told that can cure the patient, or if they read something, or in their mind they think the miracle is going to happen, or is it a religious thing, is it a personal thing? So listening and hearing, and I think that transcends culture. Now with different cultures that will take an additional layer, and I think you have to you know, really do your best to understand about that culture perhaps and learn more about it. But don't put that as a barrier that, you know, may not know every culture and what their real agenda. I think listening, you'll learn a lot. And, you know, if it's a culture that there is a you know, a translator involved or something like that, maybe, you know, a lot of times I'll engage the interpreter. You know, their role is not to translate word for word. Their role is to be a conduit, you know. So sometimes it's a language issue, sometimes it's a family dynamic issue, sometimes it's a value in that specific family. So just try to actively listen, not just hear, but listen and actively understand the dynamics. Dr. Arnold, what are your thoughts on this?
Be curious, non-judgmental, and humble.
Lovely.
I mean, the other thing is ask for help, folks. Ask your social workers who know way more about the families than you do. Ask your chaplains who are way better at non-judgmental listening than we are. Ask your palliative care teams.
Appreciate it. Thank you very much. Yeah, that's a great point to get chaplains more involved. It's something that I haven't personally even been that great about, and they're a great resource. So I think that's a great tool to add to my practice going forward. So that being said, I'd like to close this meeting. Thank you so much to Dr. Arnold and Dr. Makary for giving us your wisdom with these difficult scenarios. I know I gained a lot about it, of information from you guys that I'll immediately put into practice. And just thank you for sharing your wisdom with all of us.
Thank you for the invitation, and thank you for the wonderful discussion. I learned a lot myself as well. And thank you, Arnold, Dr. Arnold, for sharing all those awesome pearls with all of us.
Thanks. Thank you guys for all taking time out on Sunday to do this. It says fabulous things about the future of interventional radiology, that you're willing to want to learn these issues about these issues.
All right. Thank you. Have a great rest of your Sunday, everyone.
Have a great afternoon.